Hey, this is Dr. C. Nice to see everybody again. Even though I'm going to talk about a depressing topic, depression. Obviously, it's a very, very common problem. They estimate that roughly 10% of the population in the United States suffers from depression. I'm sure that the number is much higher than that because it's a spectrum of disease, basically. So we need to talk about it. The psychiatrists and the mental health professionals have trouble even defining it sometimes. In fact, it's changed a lot when they try to pinpoint it and put it into a folder somewhere. You know, they like to do the lists. They like to have everything accurate. Depression doesn't always fit there because who knows? You may have other things along with it, and most of the time you do. You may have some anxiety with it. You may have other things with it. So let's talk a little bit about depression and see if we can set some of the records straight anyway. So it's defined as a mood disorder. And you know mood, it's your feelings, your whole feelings, your personality. How do you come across? What are you thinking about? All these things, your feelings. So it's a mood disorder, but it's characterized by sadness, an exaggerated grief reaction, and a lack of feeling any pleasure out of anything you do. They call that anhedonia. You don't need to know the big names. Lack of pleasure. You just can't feel good about yourself. In fact, because then it interferes with your activities of daily living, it becomes an issue. Not just for yourself, but for the people who are around you as well. And so, those are the things that we need to focus on with depression. There are many types of depression that are defined out there, but I go by basically now the type that are in the groupings that, the codes that they use, so they can charge you a few bucks to treat your depression and all. But basically there are a number of major types. Number one, major depressive disorder. Now, okay, what is that? Well, it's those feelings that I told you about, the feelings of sadness, the inner grief. Freud used to call it anger turned inwards, you know, that type of thing. And it has to be present maybe constantly or relapsing for at least 2 weeks to be called a major depressive disorder. And remember, by this time, it has to be interfering with activities that you're doing, whether it's work, housework, whatever, but it's interfering with your life. Okay, so that's a major depressive disorder, and other things besides the feelings of sadness, poor self-esteem, poor self-worth. You may have insomnia. In fact, most of the time you do. You may have too much appetite or too little appetite. You may lose weight, you may gain weight, unbeknownst. Extreme fatigue, sort of not quite the fatigue that you get with COVID, but a fatigue, a definite measurable fatigue. And you may have some difficulties as well besides that. The women get it more than men, these major depressive disorder. Women more than men. And it tends to be in the younger age group, but I'm going to specifically focus on the depression in the elderly. Why? Because I'm elderly. Why not? And I'm talking to people who are mostly in that age group anyway. And there are differences, definite differences when you get depressed as an elder, as a senior, as opposed to when you're younger. Okay. So that is a major depressive disorder. Then there is a persistent depressive disorder. used to be called dysthymia. Oh, they love these bigger words, dysthymia, wonderful. It's a persistent depressive disorder. And of course, being obsessive compulsive, very anal, they gotta have very specific criteria for it. And so it has to be present, that this dysthymia or persistent has to be present for at least 2 years. So it's a lesser intensity depression, and people are functioning despite the presence of depression. And so it's got to be present for at least 2 years. Okay. The people who have it are not as productive as they should be. They also lack self-esteem as well. They have a lot of negative feelings. They're very pessimistic people. I know people who are that way. I never labeled them as depressed, but obviously they would fit this description of the chronic persistent depressive disorder. Okay, so that is number 2. Number 3 is one of the more intensive ones, a bipolar disorder. And again, the obsessive compulsive people have it very specifically labeled. What do you have to be bipolar? And they've even divided it into bipolar 1, bipolar 2. It's crazy how that happens, But basically, the bipolar people have to have a manic phase where they're very obsessive, very intense, and a hypomanic phase where they're depressed. So manic depression. The manic phase is usually longer than the hypomanic phase, the depressive phase. And you have to have 3 elements in that manic phase. Number 1, grandiose ideas. I'm going to be the president. I'm Napoleon. All these types of things that you can get that are grandiose ideas. You may talk a lot. In fact, talk too darn much. You can't shut them up. They may not make sense when they're talking, but they talk too darn much. They may have a high self-esteem. Trumpism, I guess, is what you may call it, a very high self-esteem. They may have a ramped up idea of what pleasure is. So it doesn't surprise me that certain politicians, a lot of politicians actually, once they get that power and all, and their self-esteem goes way up, that they may get a little bit of ramped up visions of pleasure. That's why you see so darn many affairs and stuff with the politicians and all. So, okay. They are people who like to take risks. They're risk takers. They might have, if things get even worse, they might start to get what they call a flight of ideas. One idea after the other, after the other, after the other. Now that could progress even further. That could even progress to an actual psychosis. Now, how do you distinguish between, say, a bipolar problem and psychosis? Well, psychosis, you have to really lose touch with reality. That's basically the definition. You're losing touch with reality. You begin to get delusions. You may not only just feel some of these grander thoughts, but you now begin to believe them. You have a delusion now. Or you may get hallucinations. They could be auditory, you hear things. Could be visual, you see things that are not there. You smell things that are not there. All these different things that are totally unrealistic. So, hallucinations and delusions. Losing touch with reality. Okay, so these are the psychotic breaks that you may see. So getting back to bipolar disorder, you have the manic phase where you have some of these things that I mentioned. And in the depressive phase, you have to have periods of irritability, periods where you are excessively sad, periods where you have no self-esteem whatsoever. All these things have to do with the manic depressive disorder. Okay. There are some minor ones as well. You may have a seasonal affective disorder, SAD. Isn't that interesting? Sadness and seasonal affective disorder. That's people who are, say, in the wintertime. You don't get much sunlight, very shortened daylight hours. That affects some people. They get out of their usual diurnal rhythm. And so it begins to cause a depression. Now, I kind of feel it myself towards the end of the winter. I got to get out. I got to get some, what I call fresh air, but I need to get some sunlight, for God's sakes. And in fact, the treatment of this frequently is prolonged light therapy, as a matter of fact. So, seasonal affective disorder. I feel sorry for the people now during the COVID years where loneliness, you're forced to avoid people in general. That loneliness is a form of seasonal affective disorder as well, and high incidence of depression in those people as well. Now, we get other forms of depression like perinatal depression. You've heard of postpartum depression. Well, that can be a significant one as well, and it has a significant rate of suicide. And people who are depressed in the immediate postpartum period, they're not reacting with the child, the infant, very well. That can lead to problems with the child in later life as well. So perinatal depression is another one. Now, you can also get some other minor ones like premenstrual syndrome, things like that, depression that are related to particular events in their life. So those are all of the major types of depression that we see. Okay, let's go on. There are some causes, and this is where there's a lot of argument now. What are the causes of depression? Well, let's go through them. Again, these are all theories. There's no true one cause of depression. These theories go back many, many years. The first one that really put together a coherent number of things about depression was Sigmund Freud. And so back in the late 1980s, he proposed his theories on the development of depression. Now, he thought that depression itself, I'll go here, he thought that depression itself was an intense feeling of guilt and self-blame. So he basically thought it was very similar to guilt. And we all go through these feelings of guilt when certain events happen in our life. We blame ourselves, but we get over it. Well, he thought that even a more intense form of that, where people really inwardly brought all of this onto itself, he called it anger turned internal. He called that depression. Now, you remember Freud is the one that told you about the id, the ego, and the superego. You know, he loved those terms, but those terms basically described the unconscious personalities that people had. The id was one that you were born with, and that was one that was therefore very primitive, instinctive. When a child, an infant, for example, was hungry, they cried. Well, later on, they went from the feeding type of id to the anal type of id. You know, they cry when they had a poop in their pants, okay? Or their diaper was wet. Okay, then they went on to the next stage. And eventually they got to the sexual stage as well. Freud was always, for some reason, known about these sexual connotations with all of these things. So, at any rate, the id was one that was innate and born. You were born with it. So that was driven by a pleasure principle. A pleasure principle. Okay. Now you had then the superego. The superego was your moral conscience. That's something you were not born with, but you learned. You usually learned it from your parents, from people around you when you were very young. That's why it was so important to have those parents around when you were very young, 1 to 2, that very young years. That's when you developed your superego. You developed these values and your moral tone during those years. Okay? Then the ego. The ego was driven by the reality principle because you had both of these now. You had the one that you were born with, which was instinctive, was immediate, the very first thing. And then the superego, which told you, no, you can't do that. So they were fighting all the time. Well, the ego is the thing that supposedly helped to keep those two in balance. It was driven by reality, by the reality principle. You're not born with it. So that allowed for what they called delayed gratification. Instead of instant gratification, like you would want with your id, you now had gratification, which was delayed, so that you could then function in society. So that was his definition of depression and how he looked upon it. And his theory was defined then by his treatment. The treatment was basically talk treatment. Lay down on a couch. Talk to me. Now, they're still doing it. Psychotherapists still learn all of the psychotherapy methods that were driven by Freud back in the old days. And there's still people who have that couch in their room, and they talk. So, and talk therapy still is valuable. Okay, so that was one of the potential of the causes of depression, psychodynamic causes, driven by Freud. Then you had the behavioralists. Now, the behavioralists, they thought that depression was also a learned thing. It was something that you weren't born with, but because of that time, trauma in the very young years, 2-year psyche basically, they thought that this was a learned problem. And so they used methods of trying to get people to internalize their thoughts and the people around them to accept the thoughts that the patient had. So that was all a learned experience. All, all learned. So that was the behavioralist therapy. And they still have behavioral therapists who approach it that way to try to get people to internalize some of their thoughts and improve their self-esteem at the same time. Okay. Then there's the cognitive behavioral therapists. Now, the cognitive therapists, they also established that this is a learned problem. Depression is a learned problem. And you learn then to be helpless and hopeless over the course of time. You learn to blame yourself for everything that may not go perfectly well. And so the cognitive therapist then will teach people how to approach any little failure, or when seeing even seeming failures. They teach you then how to approach it and to make it a positive thing rather than a persistently pessimistic, negative thing. They try to avoid internalizing everything. So that's the cognitive therapy, or the cognitive theory, I should say, of depression. Another theory was a neurotransmitter theory. Now, the brain itself is composed of a whole number of neurons, brain cells. Now, the neurons themselves will pick up sensations from the body and go into that nerve cell, and then there's an axon, a single nerve thread that goes out and connects to other nerves. In other words, a lot of connections that go on in the brain. Now, it goes on in all sections of the brain. If it happens to be in a certain section of the brain, which has some of the essential parts of the brain that deal with emotion, that deal with your mood, they call that the limbic section, the old section of the brain. And that's why you hear terms like the hippocampus, the amygdala, the thalamus, the hypothalamus. All of these areas deal with a lot of the emotions that we feel. And so if the neurons in that area happen to be affected, the neurotransmitters that transmit an impulse from one of the nerve cells to the other in the brain, which happens in a matter of milliseconds, very quickly. But these neurotransmitters are the important factor here. Neurotransmitters such as serotonin, norepinephrine, dopamine, GABA-aminopuric acid, things like that. They are diminished with depression. And so how did they define that? Well, not so easy. They use animal models and all to make this theory. Now, some of the stuff like the serotonin and all and the norepinephrine, usually it's brought back into the cell if it's not used. So they call that a reuptake of that particular neurotransmitter. Some of the medications that are used to treat depression affect the neurotransmission. So in other words, let's say that you get put onto a medication, which is one of the treatments of depression. Let's say that you get put on an SSRI. Well, that is a selective serotonin uptake inhibitor. So since it isn't taken back into the cell, it sits there, the level of serotonin or norepinephrine or dopamine go up. And so that's why the people who give out a lot of medications and all, that's why they feel that this is an important part of the causes of depression. There's people who don't believe all that either. Because you put somebody on, let's say, the first three selective serotonin reuptake inhibitors like Prozac or Zoloft or Paxil. Takes usually a month or two in order to get a response. Yet the response on that little neurotransmitter level is almost immediate. There's a disconnect there somewhere. So obviously that's not the only reason people get depressed, but that is one of the things that you got to take into account. Another treatment, medical treatment, is the use of SNRI, serotonin norepinephrine reuptake inhibitor. And medications like that are Cymbalta, Savella, Effexor. So there's a number of them that do that as well. Then there are the old type, which when I was back in practice, Tricyclic Antidepressants. That was it, the tricyclics. They also affected the serotonin and norepinephrine and dopamine levels as well. They increased them. And so, but they had a lot of side effects. In fact, we use them sometimes for those side effects. And so drugs like, say, Elavil or Dicipramine or nortriptyline, Imatrix, all these things are part of the tricyclic. Now they have quadricyclics as well, but they don't use them to treat the routine depression. They're usually for the bipolar or for schizophrenia, for example. Schizophrenia is one of the psychoses. Okay. We also use ECT, electroconvulsive therapy, when our medications and psychotherapy no longer work. Acupuncture is used. Suboxone is used. Sometimes they use stimulants, psychostimulants, like Ritalin, for example. That's been used also to treat depression that is really not well treated by the conventional means. So all of these things are used for treating the depression. Now, in an elder person, one of the major things they get is fatigue and insomnia. They may get confused, very easily confused. They may just move and talk slower than they usually do. They usually lose weight. They don't usually gain weight. They usually will blame some medical problem, an ache or pain. They always have some ache or pain. But the problem really is the depression. And so, for the elder people, what we try to do is to prevent it, first of all. You have to recognize it. In fact, most of the people who have depression, only 10% of them are actually treated. And that's because people don't recognize the symptoms, especially in the elderly. Some of the elderly may have it triggered, and there may be a specific trigger, a life-changing trigger, maybe a spousal death, maybe a death of a child. But there's something that triggered that particular thing in them. So, and there may be some dementia mixed in with the symptoms as well. So what do we try to do? We try to assess, first of all, are there any triggers? What with the life situation of that particular patient at the time? Try to define what you can do socially, spiritually. Can we do better with just behavioral therapy? Can we do better with psychotherapy? Can we put them on a medication that might help us? Medication alone is not the treatment for the depression, especially in the elderly. And now they're linking a lot of depression to COVID-19 as well. Why not? Everything else seems to be. Okay, that is it. I know I zipped through this quickly, and I have to apologize. This is Dr. C, and I hope you're not depressed over this whole thing. Have a nice day.